Welcome everyone to our next edition of Behind Every Drug There is a Story. I'm honored today to have with us Dr. Steve Bierman. I am going to read his bio here for everyone to understand his expertise, his background, but then really the depth and the wisdom will shine through our interview. Dr. Steve Bierman received his undergraduate degree from UCLA and his doctorate from the Northwestern University School of Medicine. After completing his family practice residency at UCSD, he worked nearly 20 years as a board-certified emergency physician at Scripps Memorial Hospital in Encinitas, California. He is the founder of 2 medical device companies and holds over 200 patents on various medical devices. Dr. Bierman is an avid surfer as well. And where do you live now, Steve? Is it still in California or have you moved?
I'm still in California. I'm
Amazing.
in a small town called Del Mar, North County, San Diego.
Wonderful. And right now, Dr. Bierman is the director of the Noetic Medicine Institute, Andrew Weil Center for Integrative Medicine, University of Arizona. You are also an award-winning author, and I have here in front of me your latest book, which is called Healing Beyond Pills and Potions, Core Principles for Helpers and Healers. And I really encourage everyone to go and get this book. It is a Bible. I have completed my first go through the book, my first read. And as I told Stephen in our chat before the interview kicked off, I'm going to go back at least 3 more times. And I have gifted it already to all of my doctor friends, physiotherapists, therapists, because truly this is foundational stuff, as you'll soon hear. Dr. Bierman, there is a quote on page 28, there is a poem on page 287 of your book that brought me to tears just this morning. And I would love to share that with our audience, everyone who's watching and listening. And I'll invite everyone to just take a deep breath. Just take a deep breath. Perhaps if you're not driving or operating machinery, close your eyes as you're listening to this poem, please, and let the words drop in. If you ask me my name, I will say healer, priest, arrogant crow costumed in white, reflecting moon. My name is sacred and distant, and sometimes too tired to care. I am death's reluctant lover, a child's guide, mother, father, hero and fool. And if you like it simple, doctor will do. Welcome, Steve. It is such an honor to be in conversation with you today. I feel that when the student is ready, the teacher appears, and I am honored to have started learning from you.
Thank you, Alex. It's a pleasure to be here, and wonderful to once again visit that beautiful poem from my friend, Dr. Richard Berland, who's, in my view, the greatest living doctor poet, and it touches me just to hear that read once more. Thanks.
Yeah. Thank you for being with us today. Would you tell our audience a little bit about the history of who is Steve Bierman? Who was he when he was little? And perhaps what is it from your formative years that you feel has shaped your life trajectory and your passion and your mission, and ultimately this work that you're bringing to all of us today?
It's an interesting question for this kind of an interview. I've never been asked that before. I'll tell you what comes first to mind.
Mm-hmm.
I'm a 3rd-generation physician.
Mm-hmm.
My grandfather and father both were doctors. When I was a small boy, I think I was probably 7 years old, my father was rounding at the hospital and invited me to come into the hospital with him. Um, I could not go into the patient room, so I stayed out in the hallway.
Hmm.
And in the hallway, I remember it seemed like 20 minutes, it might have been 3 or 4 really. I heard the incessant screams of someone who was in terrible pain.
Hmm.
And upon leaving, I asked my father, what was that screaming about? And he said, well, that's a burn victim.
Hmm.
And they're giving him morphine to make him comfortable. And it was a horrible feeling. I'm sure we've all felt that kind of helplessness before. And though I was young, I resolved at that moment um, never to go back into a hospital until I could do something, until I had some agency of some kind.
Hmm.
And I think that was quite a formative resolution. I will tell you the other thing that flashes into my memory
Hmm.
is that around the same age, um, I was watching a Walt Disney movie called Bambi. I
Hmm.
don't know if you've ever seen it. It's not watched often these days. But Bambi grows from a young boy into this wonderful prince. Bambi is a deer in the forest, the son of, the great king of the forest. And uh, running away from a forest fire with hunters in the forest, he gets shot in the chest and he falls down, and he's what anyone would think. He's over, he's a goner. And suddenly, this grand father figure appears above him and in stentorian tones says, get up, Bambi. You must get up. And you see Bambi struggle a little. And so there's life there,
Hmm.
just a flicker of life. And once again from his father, get up, Bambi. You must get up. And somehow he summons the healing forces within him and rises up and survives the ordeal. And I remember, I can't tell you why, I think it's just our common humanity. I remember watching that scene and remarking to myself, that's real. This is a cartoon, but that is real. There's something there. And I think you know my work. I think those two events um, amalgamated and brought me to the understandings we're going to discuss today.
I just love those stories. Thank you for sharing them. And isn't it incredible when we allow ourselves to go back in time and reflect how we find those really pivotal moments sprinkled in our childhood that are so important and often overlooked.
Right,
Yeah,
right.
yeah. Well, before we get to the meat of our discussion, I really wanted to learn a little bit more about the 2 decades that you've spent as an emergency room physician. And can you tell us what that experience was like for you? And then why was it important that you went through that you had that as a lived experience, specifically for the work that follows now? How does that all integrate?
Well, my residency was in family medicine.
Mm-hmm.
And early on, I always expected I would be a country doctor, so to speak, doing deliveries and following people through a lifetime. But at the end of my family medicine residency, I had a deep sense of inadequacy. I
Mm-hmm.
think I can confess that now that I'm this age. Uh, as a young doctor, I don't know that I had a real conscious awareness of that, but I certainly felt it. And I was well trained and ready for emergency work because I'd been moonlighting for the 3 years of my residency in the emergency department. So I went to work at Scripps, and I love that work. Um, it allowed me to jump from discipline to discipline, to use uh, my manual skills and my mental skills, and it was never boring.
Mhm.
Uh, it was always exciting, and more than that, it's one of the few places where the value of traditional allopathic medicine is indisputable. There was no question, and I felt adequate there. Uh, in fact, empowered. So I think that's why I found myself in the emergency room. What I discovered, though, what we all discovered, is that there was an enormous amount of suffering that I was both witnessing and sometimes causing with my procedures. Uh, and often I felt incompetent once again to diminish that. And so I began learning a series of skills. Um, I learned from the founder, John Grinder, neurolinguistic programming. But I also learned that was really a distillation. What I was learning of it was a distillation of Ericksonian hypnosis. And then I learned as things sped up and I no longer had time to do formal trance work, I was forced to learn that the ancient conceptions, even the modern conceptions of hypnosis and hypnotic method and the conflation of that with trance, these are all incorrect. This is uh, it's a monstrous confusion that really has inhibited our understandings in medicine and more broadly in our understanding of humanity. And so I worked to uh, tease out what the truths were so that I could apply those understandings at the rapid rate I needed to in the emergency department. And it was quite a fruitful laboratory because where I worked, there was one doctor, and you might have, 3 to 5 nurses, but it was an open playing field. If I thought of a potential method for alleviating someone's pain, there was no one to say no. I could just go in and do it. And so I developed many, not all, but many of my tools in the emergency department over those 20 years.
That is fascinating how we are already always where we're meant to be.
Yeah,
There's no such thing as a wrong step in career and personal life. It all gets you ultimately to where you're meant to be and in the direction you're meant to go. So that is wonderful, and it's exactly what you said. You were both witnessing suffering, and thank you for sharing and being really vulnerable there and causing suffering, because that awareness for all of us physicians in clinic, whether it's ER or non-ER, non-emergency medicine, we've all done both. Yeah.
yeah, absolutely.
So before we go any further, and I really want to talk to you about specific methods of your work and everything you describe in the book, could you tell people what noetic medicine is?
The word noetic refers to mind,
Mm-hmm.
and as I use it, it focuses really on the conveyance or the possession of ideas.
Mm-hmm.
Noetic medicine simply put, is about the impact of ideas on health and healing.
Mm-hmm.
We've all been taught, you know this, we've all been taught a science that is devoid of all things noetic. There are no ideas in the physical world of, depending where you want to go, of, elementary particles or zoom out atoms, molecules, cells, tissues, organs, and so forth. There's a lot of stuff there, but none of it is mind stuff. And yet, we're all using our minds right now to understand each other. And we all have mental experiences attendant all of our various physical experiences as well. And so the notion that mind has really no role in health and healing is absurd. And I think we all sense that instinctively, but we haven't been taught that. And so sadly and regrettably, this wonderful tool that we have, our minds, this thing that emergent qualities that distinguish us as human beings, we tend to ignore in the practice of medicine. And it's my uh, really strong insistence that we begin to include things noetic in our thinking about both our patients and our behaviors and interactions with those patients, because it makes a difference. It makes an enormous difference, and even to the point where sometimes, as you know, you've read the book, it's life or death.
It most certainly is, and all of us have at one point in time sat across from a caregiver, from a healthcare professional, from a doctor, from a nurse. I was in a doctor's office only a few weeks ago with an injured ankle, and I was listening very carefully to the words that were being told and how, with awareness and paying attention, if to how those words could impact me if I weren't necessarily paying the attention that I was, and really filtering them to see, is this true? Is this not true for me? To your point of doing both good and doing harm with the words that we convey to the people that we care for. You've also touched upon the causality model as well, and really the reductionalism that's present, that excludes the mind, that excludes the psychological factors from consideration. Could you tell us a little bit more about that and how you actually introduce this through your work?
Well, I think it's very important. We never, as physicians, talk about causality, even though we have a fundamental notion of causality that underpins everything we do. Our reductionist science, the biomedical model, or materialistic science, however you want to call it, begins with what I call blunt beginnings. There's a mutation, there's an exposure, there is a defect. And those lead from that particular blunt beginning to the next physical, the next physical, the next physical event, ultimately resulting in signs and symptoms. That's what we're taught. There's no idea, noetic element in any of those causal sequences. And we're all taught that, and we're so overwhelmed during medical school. And we're ourselves, actually, we're so helpless and dependent, and our professors are so authoritarian, that we're inculcated with this notion of a purely physical causal change resulting in the various ailments we're charged with treating. It's not true. It can't be true. And I think everyone has some sense of that, unless you've really been deeply indoctrinated in this. What I offer, though, I don't want to throw the baby out with the bathwater, right? The allopathic medicine that we have, not always, but in many, many cases, is remarkable. And in more cases, if not remarkable, it may yet be the best we have at the time. But there's something more, and we all know what it is. It's the mental state, the ideas of the patient, ideas which sometimes come from us and how we speak, and which sometimes they hold themselves. And so I place those at the beginning. I call them Zone 1 causes, and I have a chapter in the book on the nature of symptom formation. And Zone 1 causes includes, of course, extrinsic causes like, exposures of various kinds to microbes or toxins or so forth. intrinsic causes, which have to do with, say, matters affecting host defenses. Um, it may be something as simple as low vitamin D, uh, which we know is a major intrinsic cause of many ailments. Or it may be something more significant and more broad-reaching. Um, but I also then include noetic causes as zone one causes. And what I've learned and what I would ask everyone to consider um, is that when we treat only the physical down chain events, we can often interrupt the sequence that's causing the presenting signs and symptoms. But if we don't treat the zone one causes, the mold in the house, the guilt that's condemning the patient, the low vitamin D, if we don't treat the zone one causes, some other syndrome will arise. And that's why I say today's traditional way of thinking of the causality of disease involves these blunt beginnings and endless endings. Just look at the charts on your patients. You see a chart that big, you haven't cured them, right? But what I've learned and I did emergency medicine, but I should say I've had a private practice here in Del Mar for almost 45 years now. And so I've seen gobs of patients over the years with every imaginable diagnosis. And what I've learned is that not always, but often, when you address all of those zone one causes, respecting the noetic causes as well, the chart thins. And these people don't come back time and time again.
Amazing.
You actually do what you wanted to do before you started medicine. You wanted to come and ignite the intrinsic healing properties within your patients.
Yes.
The thing that got Bambi up, you ignite those intrinsic healing properties.
Yeah.
Sometimes with your words, sometimes with your gestures, sometimes with your medicines. And when you do, they get well and stay well.
That is absolutely incredible, and what a gorgeous offering and an invitation for all of us. When you've mentioned the blunt causes, and you've mentioned G's and exposure, we will have a lot of oncologists listening to this interview, and clearly genes and exposure to a whole host of environmental components has been linked to any one of the cancer diagnoses. And so I really wanted to reiterate that this is important for every single specialty. It's not only applicable in the ER where you started and developed a lot of these methods and continue to practice. As you've just said, you've seen probably thousands and thousands of patients over 45 years now, as you've mentioned, with a whole host of acute and chronic conditions. So it just works across the board because it is that foundational. And it taps into the balance within our system. I want to give you the opportunity to say what you just started. And perhaps as you do that, if you can tell us a little bit about homeostasis and where that originated from, and how does it tie in to the factors you were just describing?
I'm happy to do that. So there was a great physiologist, medical researcher, writer in the last century named Walter Cannon. And I commend him to everyone, his writings. I came upon the work of Walter Cannon by reading his 1942 article on voodoo death. I had many reasons to be curious about that. I was exploring the literature, and I happened on an article by this eminent researcher where he explained his proposed theory of how voodoo death. He gave, I think, three or four instances where it had apparently occurred, And he explained physiologically what might have happened and gave what we'd call a scientific rationale behind it. Now, um, people listening, even your oncologist colleagues may say, yeah, well, that's in primitive society, and those people are superstitious, and therefore they were susceptible to the evil witch doctor's curse. Um, yeah, I'm sorry it doesn't work that way. It has nothing to do with their primitivity, uh, quote unquote, because what drives a voodoo death is what drives something that we've all witnessed, something that we've witnessed, in fact, in every single randomized control study ever done, namely placebo and nocebo effects.
Yeah.
And let me explain this, because I think, especially for oncologists, this is, as I say, this is probably the most important thing for physicians to know, because it has so many far-reaching ramifications. Uh, Dr. Weil and I just published in Frontiers in Psychiatry a extensive paper on placebo. And I think it's a groundbreaking study that finally, for once and all, explains what's going on, both mechanistically and sort of broader philosophically with placebo. It's very simple. There's a law that governs human behavior called the law of identification. And what it says is the degree of identification, let's in this instance say of a patient with a doctor, the degree of identification between these two is directly proportional to the helplessness and dependency felt by the patient, and inversely proportional to their uncertainty about your competence to help them. This law penetrates throughout the species. And it's very easy to understand that it's primordial in that when are we most helpless and dependent? When we're children.
Yes.
When are we least uncertain about the one caring for us? In our infancy, well, with our mother or our father, we hope. I mean, for most of us, let's say. And so we identify with them, which means their ideas become our ideas at a deep level, so that they become operative. Their aesthetic ideas, their moral ideas, their ideas about religion and the goodness and badness of ourselves and others, and so on and so forth. It's a wireless download, if you will, of their reality into our unconscious minds. And that is what I mean by identification. Now, let's go to the present day where we're not helpless and dependent anymore. And we're scientifically skeptical, so we have doubts about everyone's abilities. But there are times when identification is once again triggered in adult life. And you oncologists know that better than I think anyone in medicine, except perhaps surgeons. Those times are when a patient receives a dire diagnosis. I'm sorry to say, it's not what we hope for. The diagnosis is cancer. At that moment, that patient is so helpless, I can't fix this, and so dependent, I need someone who can. And you, as a physician, are perceived, like it or not, we all try to do shared decision making and avoid medical paternalism, and we've all been taught these things. I'm not talking about things on the surface. I'm talking about our fundamental biological hardwiring.
Yes.
And so the patient at that moment, like it or not, want it or not, identifies with you. And so what you say matters profoundly. It can have enormous effects down the road.
Yes.
And I have seen that. I've seen it work both ways. I'll remind everyone, Bernard Lown, Nobel Prize winning cardiologist, years ago, told us all, words are the most powerful tools doctors have, but they can maim or heal.
Yes.
It cuts both ways. And so that's what noetic medicine is about, of course. It's about learning to say it right, to convey it right, so that this tool we have, by virtue of being just who we are, we're just caregivers. You know, but this tool is the result of this prevailing law of identification. And so we must learn how to speak. We must learn how to deliver. We must learn how to form alliances and allow for the retention of hope regardless in our patients. And that is the business of noetic medicine.
Amazing, amazing. Now, I will ask you to give us some specific examples of what that delivery can look like, both ways, for comparison. But before we go there, there is this one question that is really important to reveal those depths that are alive in the patient, that bring them to us with presenting symptoms. And that question you've learned in your work is, why today? If you had to guess, just guess. You don't have to know, but if you had to guess, why today? Can you please give us some examples of what unravels?
Some examples of what that
Please,
reveals.
there are so many in the book, and all of them are brilliant, but a few that stand out for you, perhaps.
So let me say to your audience first, this question, it's the most important question you can ask a patient. It has to be asked in a proper way. And you did a brilliant job, Alex, of asking it. And it's the lever that pries open the box, that shows you don't have to believe me. You don't have to believe the book. All you have to do is ask this question of patients, as I have now for decades, and you will become convinced beyond any doubt that ideas, in fact, perhaps not always, but almost always play a role in the etiology of disease. And so I'll tell you my first patient, and then let me tell you the sort of categories that spill out over the decades, and especially the ones that affect cancer patients, if I may. My first patient was not a cancer patient. I dreamed up this question while reading an essay by Robertson Davies. And I thought, oh, I can't wait to take this to the ER and try it out, right? And so my first shift, picked up the first chart, and it's a gentleman, 42-year-old gentleman with left-sided testicular pain. And I thought, well, okay, here we go. Examined him, got the labs, did everything. Turned out he had epididymitis. And I gave him his prescription and his referral. And of course, normally in a fast-running ER like that, I'd be out the door and on to the next. But I thought, no, I'm going to do something different here. I'm going to ask my question. And so I was almost out the door, and I turned around and I said, hey, you know, you're not going to know, I'm not going to know. Maybe this is a dumb question. Why did I do that? To suppress all resistance. It's like I'm saying to him, this doesn't even matter, so you don't have to resist, right? But I'm just wondering, since we're not going to know, if you had to guess, this could have happened 3 days ago, 3 weeks ago, or 3 weeks from now. Why today? Why do you think it happened today? Just guess. That's how you ask it. Offhand, as if it doesn't matter. The answer will always be the same. It will always be the same initially, because they'll say, Well, I don't know. You're the doctor. And so you just roll with it. You say, yes, you're right. I'm the doctor. But remember, I said I don't know, and I'm not expecting you to know. Just guess. Why now? Why today? And the answer usually comes as a question. That's important to know too. The guy's putting up his pants and zipping up and getting it together. He turns around and looks at me and he says, I don't know, Doc, but do you think this will have anything to do with the vasectomy my wife wants me to get tomorrow? And then I knew I was on to something.
There we go.
Then I knew, this is a magical question. Now, I deal with a lot of cancer patients every day. And what you will learn by asking that question, if you really do it right and listen, sometimes you have to just, while it's percolating up, you have to sit silent and let it come to you, the final answer. But what I've learned is this. There are a group of noetic causes that get exposed from asking that. Common ones are these. One, curses, what I call curses, by which I mean negative suggestions from authority figures. That can come from a parent, a priest, a physician. Someone reaches out their hand and, oh, I'm so sorry, at best you have only 2 years to live. A curse like that is just like Walter Cannon's voodoo curse. Be careful. You'll find also what I call baleful wishes, unhealthy wishes. I wish I could get out of this relationship, job, situation, no matter what. Beware the no matter what wish.
Yes.
We should all never do that. You can wish to get out of a situation in a healthy way. But when people issue no matter what wishes, which they do commonly, often illness ensues. Guilt, in the Judeo-Christian meaning of that term, entails punishment. And so you'll often hear, in answer to the why today, some form of guilt expressed. These are very, very common causes. There are others, and I outlined them in the book. But what you'll see is that by asking this, the patient gives you something you can work with. Because if it's a baleful wish or a curse or a guilt syndrome, there are ways to treat those. And in treating those, you've eliminated at least one of the contributory causes of their illness. And so when you do that, you stand the chance of affecting a cure.
That is incredible. So for everybody, try this in your clinics. If you take anything from today's interview, then take the why today question and listen to how Steve guides us to ask that question. Just watch that part again, listen to that part again, take it into your clinics and see the magic happens. It cannot fail. It just does not fail. And I've been doing it in my clinics for over 3 years now, and it is absolutely magical. It just opens a lot of beautiful opportunity for connection. It really does. Steve, I tried, this is a mini course in this book, not a mini course, a big course in this book. And I was jotting down these beautiful steps that you so skillfully and artfully use. And I use the word artfully very deliberately because I would like you to speak later about the exquisite art of caregiving, of healing. But here's what I've put down together. Please tell me whether these are really your steps, because I was reading the examples of your interventions and connection with the patients throughout this book. And I was like, what is this that Steve is doing? And this is so beautiful. So really connecting, really being present and dropping in, and ideally being regulated yourself as a physician. And then placing the fear in the past, because there's a lot of fear that can be present in our patients in the clinic, especially when there's uncertainty and when it's life or death, when it's a diagnosis such as cancer. And there's ways to do that with our words with patients. Synchronizing our breathing with the breathing of the patient, super important. Really catching that cadence, very deliberately syncing. Eye contact, really important. Nodding our head as we're speaking to them to really reassure and reaffirm. And then also saying words like, as we're doing that, that's right. But then also waving away, very deliberately gesturing away those perhaps negative contexts and connotations that are not going to be useful in that particular moment for the patient. With all of this, there are some beautiful instructions such as just listen. And very carefully using our language and not using the misplaced you, but rather using the words other or some. So could you give us an example of what this looks like in your clinic? And first of all, please, can you please scrutinize me for my notes?
So what you've covered there is a broad range of many techniques that are all derived in some form or fashion really from the artistry of Milton Erickson,
Okay.
the father of modern medical hypnosis. Let me ask everyone though, when you hear me say the word hypnosis, please don't think trance, because hypnosis is not trance. Trance is an effect of hypnosis, but you can also affect hemostasis and analgesia and tumor regression and all kinds of other things by igniting the internal healing capacities of your patient. So when I'm talking about hypnosis, I'm talking about ways in which you increase the likelihood your words will have their desired effect. And so there's rapport, which is a set of skills that allow you, as you say, Alex, to sync with the patient.
Mm-hmm.
And frequently those involve breathing the same, matching their vocal energetics, head tilt, eye blink, head movements, word choices. In other words, you want to diminish the differences between you and your patient in order to develop the sense of rapport. It takes some practice. You don't want them to know you're doing it, but it's an imitative skill that you can do in various measures to link more tightly. It's important to know, however, that as oncologists, for example, chances are they're already in rapport with you.
Mm-hmm.
And so you don't have to spend too much time on it. The other has to do with the words we choose, the other aspect of hypnotic technique. And linguists like John Grinder, who's a PhD linguist, make the distinction between words like you and words like them. They're called referential indices, and there are specific referential indices, you, and general, them, others, they, patients, some. And this is a very important distinction. And let me show you a technique I call the on the one hand and on the other technique. And let's say this is about, I'm going to offer chemotherapeutic agent. And just for brevity, it can cause nausea and vomiting. Okay. And let me first show you the wrong way to do that. And I want to offer this tender advice. As I do this, many of you will realize you do this. But understand, none of us were taught the impact of ideas on the health and healing of our patients, the distinction between specific and general referential indices, the skills that I'm going to lay out in this simple little exercise. We weren't taught that. We were rather taught that if you're compassionate, that's enough. And that's why my first chapter is compassion is not enough, because this kind of mistake gets made. Let me show you what I'm talking about. I'm speaking now to my patient. So I'm going to recommend that you undertake this chemotherapy medicine. It's very strong, and it offers the opportunity for some improvement here. But I need you to know that you'll probably have nausea and vomiting, and when you do, I need you to just contact me and I'll try to help you with that. Okay, there's so much wrong in that. Let me tease it out a little bit. Try implies an obstruction. Okay, try to help means I might not. When you do, instead of if, implies it will occur, whereas the word if implies if not as well. You will. Here's the thing. Let me invite you to explore this. And if I had more time, I think I could convince most of you. You will is a phrase we're not entitled to use in clinical medicine because we never possess, as a result of our statistical and anecdotal knowledge, we never possess that degree of certainty with respect to the patient before us. So you will, I'm sorry, is wrong. You could, you might, you may, but you will is something you don't know. That's informed consent done wrong. Now let me show you the on the one hand and on the other, okay? Same drug. I'm going to recommend this chemotherapeutic agent because in many people, perhaps like you, it can have a very, very salutary effect on your health. Some people, again, perhaps like you, are even cured by this. But I'm obliged to tell you the risks and the benefits of it. You'd like to hear that, wouldn't you? Very well, then. Let me speak to the risks first, okay? Now look what I've done. I put the risks over there with my right hand. On the one hand, some people might have nausea and others nausea and vomiting. And if they do, I need them to contact me right away so I can give them what they need to be comfortable. I've given the risk, I've said it honestly, and I've put it over there. On the other hand, there are people, perhaps, I use the word perhaps so I can stay honest, perhaps very much like you, take this drug, enjoy the benefits without any side effects whatsoever. Okay? What I've done is I've used you and my hand that way, and I've given the direction for the more favorable outcome toward them. And then I'm going to incorporate my sort of standard goodbye, because words matter the whole time. They've identified with me. So I'm going to say to them, I've said, uneventfully, without side effects. Let's start this. I'm saying let's because I'm forming an alliance with that, let us. Let's start this medication and see how well you do. Tell you what, why don't you call me tomorrow and let me know how well you're feeling. See, you mentioned greetings. Greetings, those are your first chance to establish rapport and place concerns in the past just by saying, oh, well, I imagine you were really worried about that, weren't you? And they say, yes, they've assented to placing that in the past. Now with my goodbye, that simple little goodbye, why don't you call me tomorrow and let me know how well you're doing? I'll often tag this one on because it's so fun. And please, don't be opposed to pleasantly surprising yourself. And what I've done there is when I give them the don't be opposed, that double negative, their conscious mind is untangling that. I've inserted a pleasant surprise, which is that you'll be comfortable. You won't have nausea and vomiting. Your stomach will feel fine, and you'll, as many of my patients do, have your chemo and then go get a cheeseburger. Um, so think about that. It matters so much. If you give informed consent, risks and benefits out there. I mean, risks out there to some people, someone, patients, others, and benefits perhaps like you. To them, call me tomorrow, let me know how well you do. What you'll see in your practice, and you'll feel so proud and gratified from doing this, I promise you that. Um, what you'll see is that, in fact, of course, those patients do better. Now, just quickly, you might say, well, what proof do you have of that? I have more proof of that than anyone has of any other fact in medicine, because what drives that is what drives placebo effects, which we've seen in every single trial since 1909. And that is, they're identified with me. They're helpless and dependent. I'm the one they're least uncertain about.
Yeah.
And so the law of identification makes my words, my ideas become their ideas. And perhaps you'll enjoy all the benefits and be well.
That is brilliant. Absolutely brilliant.
And that's so
Really,
simple.
it is so simple. And to your point, we weren't taught, we weren't trained this way. We are hopefully shifting out of being indoctrinated to being a doctor, to remembering what a doctor really feels like, means, looks like in practice. And this is the foundation. It really and truly is. And you speak in your book about hope and alliance, and that patient caregiver relationship, and you've demonstrated that so beautifully. And also really the level of responsibility and integrity that we must have and hold and uphold and be present with and for, in order to show up, to practice acknowledging the noetic causes and the principles of noetic medicine.
Absolutely.
Yeah. Steve, we could talk for so many more hours about your book, about your work, about the teaching that you do. Could you please, as we're wrapping up, if I've missed anything, if I haven't asked you something that's really important for you, that's on your heart, that you would like to share with our audience, please do so.
Well, as you've suggested, Alex, the study of noetic medicine, it takes a little time, and it takes much effort. You have to gradually integrate this into your habits of speech and gesture. But it's easy. There's nothing complex about it. I think if I were to wrap up, I would say this. Um, all of us came into this uh, because of certain thoughts and ideas and intentions that we have, not because we were cells and molecules and tissues. It's those emergent properties that make us human that drove us to this calling, caregiving. And I think wherever you are in your career, that it serves you and serves your soul best to return to that basic humanity, and to realize that everyone you confront has it. This job we do is very, very hard, and we're prone to hubris because we need to puff ourselves up to overcome self-doubt. But there's another way to do it, and that is to just realize we've taken on an impossible task, and all we can do is our best. And I can guarantee everyone listening that if your best includes watching your words, understanding not just what you know, which is a lot, but also what you don't know. You don't know the future of any single patient. You're not a prophet. And in the humility of those recognitions, to cultivate this talent, the talent of using ideas as medicines and igniting within your patients what they have and what you have, which is these innate capacities to heal. And if we do that, and this is why at the age of 75, I'm still seeing patients 6 days a week. If you do that, your work becomes so deeply gratifying. It's a personal thing. It's yeah, you're doing great things for others, but personally, it becomes so deeply gratifying that you can't wait to get to the office. And so I invite you all to share that with me. That's the big reward. That's what this is really about.
That is so beautiful. I do not want to dilute your powerful words and your wisdom with any further questions. I would really just like to thank you from the bottom of my heart for being in this world, for offering your wisdom and knowledge. And personally, I want to thank you for being my teacher.
Uh, my pleasure, and I thank you right back.
Thank you.